medications, whether they're used in the nervous system, whether they're used for cardiology, whether they're used for respiratory, for the endocrine system, they all bleed into other systems, as you can see. Like I talked about before, the body systems do not work in a vacuum. Each system relies on another. If one system is down, the other one goes down. It's kind of like a spokes on a bicycle. A couple of spokes break, what happens? The thing collapses. In the body, the same thing happens. That you affect one part of the body, it does not work very well, or does not affect it appropriately, then other body systems can be affected as well. And the effects. We can see there for alpha-1 what it does. We will be seeing some of these medications again when we talk about cardiovascular, because they do the same thing. But what's happening here is that we are specifically looking at these for the nervous system and how it's affecting the central nervous system as a whole. And you can see all the different issues that are going on with these medications. We have alpha-1 and alpha-2, and then we have beta-1 and beta-2. We have alpha-1 who increases the cardiac rate, correct? So increased cardiac contractility. So it contracts more effectively and more efficiently. When you go to beta-2, what's happening? The same thing is happening. So we add increased heart rate. We look at increased blood pressure. Those things that are happening as we're affecting the nervous system. As we go into that one next week into cardiovascular, the heart works how? What causes the heart to beat? Electricity, exactly. Where does that come from?
Yes, they know.
It comes from electrodes in your neck. And every night you got to plug yourself in and fly the kite, lightning. It comes from the nervous system, doesn't it? And impacts what's happening in the heart. As we're affecting the nervous system, we can see that those things are being affected throughout the body as well. So we're having issues with respiration, with bladder, with bowel, and so forth that are happening because we are affecting the nervous system. Just not making you happy or sad or goofy or whatever. It's affecting other body parts as well. Does that make sense? The biggest thing to understand is when you look at these medications is that if they are non-selective, and most of these are, it means that they are affecting other parts of the body that the nervous system is affecting. And that's why when we give one medication that helps a person to maybe speed things up. They're always depressed or slow, so we want to speed things up. Well, now they're happy. Now they get going. Guess what else happens? The heart rate goes up. The blood pressure goes up. They have vasoconstriction. The respiration rate can go up. Why? Because we're affecting the nerves. We're not affecting that particular organ, but because we're affecting the nervous system, we're affecting all the rest of the body. Does that make sense? Once you get to understand that. Very important. We'll be looking at some of these separately. Dopamine is one of my favorite drugs. Dopamine is a happy drug. It's kind of like adding red wine and chocolate. You can put that in a little capsule and have dopamine. Do not try that at home. Do not go home and start mixing things. Oh, my
You actually got to drink this like that red wine with chocolate.
Neurotransmitter inaction or inactivation. When you put those two words together, what does that tell you?
Not active. Not active.
That it's stopping or it's slowing it down. It's not having the same action anymore. So we have the reuptake of the transmitter back into the neuron, the enzyme transformation or degradation. So we're not having that action from nerve to nerve, so everything slows down. And we'll see in some medication how that works. We have MAO, and we'll look at the whole name of that. I'd rather say MAO because that's a mouthful. Work within the neuron, and then the other outside the neuron. We'll be looking at this. Diffusion away from the receptor. You remember last time we talked about the medications are specific to different organs because of receptor sites? Same thing is happening here, but instead of the organ itself, it is the nerves within the organ that these are affecting. Remember your nerves? Your axons, your dendrites, and all that stuff? How the impulse goes from one to the other across the synapse. And if you have high action within the synapse, things go faster, and if you slow it down, things go slower. If you look at somebody who's a type A personality, things are going 187,000 miles per hour. That's happening all the time. Brain waves are going all the time. You get somebody who's depressed. Same nerves, same receptor sites, but something's going on with the chemical action within the synapse, which is causing these things to speed up or slow down. That's what these medications do. So when we speed things up or slow it down, it's affecting other things that these nerves are affecting, like the heart rate, respirations, and stuff. Okay? Okay, I see a lot of you smiling, your type A personalities. I can see that. Depends on the day. Oh, it depends on the day. I was dancing this weekend. Oh, by the way, I came in first. I did. Not in all of them, just in one, but that was enough. And we'll look at when it says norepinephrine reuptake and degradation, how that affects the synapse and the neurotransmission and so forth. We'll see how all that works. Is that we have these drugs that halt termination of the neurotransmitter, and we'll see how these work and either pulling them back or making them come out further affects the individual. Classification, we have direct acting, we have epinephrine and norepinephrine. And then we have indirect, like amphetamine, and long acting like ephedrine. You ever hear that word ephedrine before? Mm-hmm. Where do you see that? Diet pills, you bet. It was outlawed, you know. Ephedrine causes death, so they outlawed it. Guess what they put in the place of ephedrine? Ephedrine. Yeah. They just renamed it. If you look at the packaging a little closer, you'll see that it's pretty much the same thing, just a little bit different name. But that's another story. Okay, we have our catecholamine, which epinephrine, norepinephrine, and dopamine come into. We have those that are naturally produced. We have those which are synthetic, as you can see up here. And non-catecholamines. must have longer duration action than the other. And then you see the instances that you have below. You will be dealing with these different medications as you're working with patients. You will see these. And understanding that the duration of action is very important. So we have epinephrine. What's epinephrine used for more than anything else? Allergic reaction. Allergic reaction. Yeah, cardiac. Are they still using epinephrine? Because they went epinephrine, atropine, something else, didn't they?
I think we have atropine in our current.
Do you still have it?
Like that's the first line.
What was it, about 6 years ago, they revamped the entire ACLS and changed everything. But, and I don't keep up much anymore. But epinephrine, increased blood pressure. How do you think it increases blood pressure? Not by making the heart faster. Okay.
Constrict blood vessels.
Okay, constrict blood vessels is one. What's the other part? Contractility. Okay, rather than the increased heart rate, what it's doing is that increasing blood pressure by vasoconstriction and by contractility. So the heart's beating harder rather than faster. Faster is in there as well, and anyone who's had epinephrine or had allergic reaction was given that, or had asthma and they were given that, they can attest to the fact that once they get it, they're ready to leap tall buildings with single bound and run around the block 87 or so times because it really gets you excited. It causes vasoconstriction, but it also causes bronchial dilation. Why would that be important? So they can breathe. Put those two things together. We have increased blood pressure because of vasoconstriction, because of contractility. What do we need in order to support that? Oxygen. Now we have vasodilation. Contraindications, as you can see here, for increased blood pressure, hypertension. You don't want to do that. Cardiac arrhythmias. What's cardiac arrhythmia? Okay, irregular heart rate. As the heart rate increases, these increase. So your dysrhythmias increase with increased heart rate. You have them more often. Hyperthyroidism. That's your ephedrine. When it says, we are readjusting your internal furnace in order for it to burn fat faster and make you more efficient and turn you into the body of Arnie Schwarzenegger before you turn 50. By affecting your thyroid. Ah, that's how they do that. Yeah. Look what it did for Arnie Schwarzenegger. He got old and started messing around with a maid. So don't take it. You get old and start. No. Actions. Inotropic, vasoconstrictor, bronchial. Okay, bronchial dilator. What does inotropic mean?
It strengthens the myocardial contraction.
Ah, so now rather than saying all that stuff, all we have to do is say it's inotropic action, don't we? You guys hear that over here? Increased cardiac contractility, vasoconstriction, all those things that happen along with the medication, or inotropic, depending on what school you're from. And the uses we talked about already, in these cases.
To make it hard.
Questions?
Well, sorry.
Side effects. Kind of talked with them already. So some of the side effects is cardiac dysrhythmias, hypotension is a paradoxical response. We have flushing, that means you turn red. Reflex tachycardia, decreased renal perfusion, and drug interactions, beta blockers decrease, and digoxin causes cardiac dysrhythmias. Question? Nursing interventions. If you, on the nursing interventions, if you understand what is happening within the body, what the drug is affecting, it's causing contractility, it's causing vasoconstriction, bronchial dilation, so on and so forth. If you understand that, then you should understand which body systems you need to monitor. Does that make sense? Mm-hmm. Vasoconstriction, what do you monitor? No, that's one of them. That's good. That's one. What's the other one? No. Urine output. Urine output. If you're constricting the blood vessels, you're not having the blood flow through the kidneys to get rid of all the stuff, right? Does that make sense? But yeah, high blood pressure, pulse, all that stuff goes in hand. But remember, it does not work in a vacuum. It affects other parts of the body as well. So if you understand what the medication is doing, without having this list here, you should be able to come up with a majority of these issues. Just by understanding the anatomy and physiology of the body and how the medication is affecting it, you should be able to critically think to that point of saying, it's causing a faster heart rate and it's causing blood pressure to squeeze down. What should I be watching for? Aha, you should be watching for blood pressure, cardiac arrhythmias, and you should also look at output and so on and so forth. And look at things as far as teaching is concerned. Avoid cold medications that may have medications that are either going to enhance or degrade the others. And then diet pills. You know, most diet pills, they have either caffeine. Green tea is good for you though, right? Mm-hmm. What's in green tea? Lots of caffeine. I had a friend one time who said he never drank Coke because Coke has lots of caffeine, so you can never drink Coke. But I'll have 4 or 5 cups of hot cocoa. Guess what has more caffeine? Hot cocoa. Why do you think Santa Claus is so jolly? He gets cookies and caffeine. Come on. Prevental. What's this medication used for? Asthma. It's a bronchial dilator. Bronchial dilator. And how does it cause bronchial dilation? Through what system? The nervous system. You can listen. Thank you very much. Again, we have bronchial dilation. We have a component of vasoconstriction along with this. Therefore, we want to watch out for some of the same things that we had to deal with epinephrine. That comes under the same category, correct? Side effects. Well, some of the side effects are the same thing as for epinephrine. Why? It's in the same category of medications. if you learn a category, the catecholamines, and you go, okay, I have preventable, I have epinephrine, whatever else, you realize that the side effects are going to be the same, the actions are going to be the same. When we get into the cardiac drugs, you'll see that even more pronounced within in a category, what each one does, and if you understand that category, but not necessarily each individual drug, but that category, then you know all the things. It's like with antibiotics. Major side effects of antibiotics. Gastric distress, nausea, vomiting, diarrhea, rash, pruritus. That comes with toxicity. So with antibiotics, those are general side effects. The actions are the same. They either kill or attack bacteria. Now how they do it's a little bit different. But that's the general thing it does. When we look at cardiac medication, it's the same thing. When we look at the in the nervous system based on the category, they're doing pretty much the same job. Okay. Where like epinephrine causes major vasoconstriction, hypertension, and bronchial dilation, albuterol has some vasoconstriction, but not as severe as with epinephrine. And its major benefit is bronchial dilation, so that the person can breathe more easily, like with COPD or with asthma. We put them up with some other medications. We will go into the sympathomimetics. We will be going into the MAO inhibitors. We'll talk about that also. MAO inhibitors, basically you can't breathe with those. It's a very bad medication, but in some cases last resort. We'll talk about that as we go into some other areas. Adrenergic blockers block the effects of the adrenergic transmitters, directly by occupying the receptor sites, indirectly by inhibiting the release of neurotransmitters, epinephrine and norepinephrine. We're affecting that synapse again. We're affecting the speed of the responses between nerves, which are causing the responses within the body. We have alpha-1. How is this blocker different than the catecholamine you just looked at? How's it different?
It blocks the sympathetic.
Just the reverse. Instead of vasoconstriction, what do we have? Instead of high blood pressure, what do we have?
Low blood pressure.
Okay, low blood pressure, hypotension. Pupil constriction, and as you can see, the rest there for, etc., etc. If I have to explain that to you, later. I may not.
Sounds right.
I could hear that from over here. Okay. So basically what we're doing is we're doing the opposite from the other medication, aren't we? Almost exactly the opposite. This is all that's happening within the nervous system. We are not targeting a specific system within the body, but affecting the nervous system as well, which inadvertently or on purpose affects the different systems within the body. So we have selective and non-selective. What's the difference?
One is specific, one is everything. All
Okay.
of it.
You're all right. What I heard was, okay, but I picked some of it out. It's, well, one, it's got a specific receptor site, and the other one just kind of bounces off and sticks onto whatever you got. And the action and uses, as you can see, we will see these medications again when we look at cardiovascular. Again, your blockers are doing just the opposite of the adrenergic or the catecholamines. Questions? Just making sense. Okay. And we have our medication. We have non-selective propranolol or Enderol. Contraindications with COPD. Why would it be contraindicated in COPD?
Can you repeat the question?
Nobody was perfect. He started it and you finished it over here. Perfect. I liked it. Basically, vasoconstrictor or a bronchoconstrictor. Oh, if you got COPD where you can't breathe very well, the last thing you want to do is shut off the airway. Someone's SE and AR, side effects, and adverse reaction. We have weight gain. Impotence does not mean you're important. It's like the guy went to a doctor and came home in a suit. He said, "Why are you wearing a suit?" The doctor says, "I'm important." Sorry. Decreased liver. They're just floating around in there, folks. I just don't know when they're going to come out. Just bear with me. Drug interactions, as we can see here, is that and then heart block may occur with medications, the dioxin and calcium channel blockers, which we will go into more depth later on. Selective beta blockers. Beta blocker 1. Decreased blood pressure and pulse, fewer side effects. Example, we have low pressure, atenolol. It's really interesting. Some of these medications are perfect. They tell you exactly what they're supposed to do. Low pressure, what do you think that does? Lowers blood pressure. Isn't that exciting? I wish. They're all not like that. We have drug interactions that the medication decreased effects with the NSAID, increased effects with the other medications. We see here an increased risk of hypoglycemia. And you will see this a lot with a number of the cardiac medications as they come under the beta 1 and beta 2 blockers. Is that we have our insulin and sulfon, as you can read it there. Does that make sense? Blocks to release norepinephrine. You have to understand that these catecholamines are where? Where are they located?
Nerves.
In the nerve synapses. They are between the nerves. These are the things that are dictating how fast and how slow the nerve impact or the nerve conduction is. That's why you have a fast heartbeat. So how fast is the nerve conduction? Very quickly. Because we have the use of epinephrine, norepinephrine with these catecholamines within the synapses, which are causing the nerves to run faster or slower. But in doing so, it affects other parts of the body as well.